I'm Roos from the Clinical Outcomes Research Unit at the University of Melbourne. I'd like to share an overview of our work in which we developed a method to measure the duration of therapeutic lag in multiple sclerosis. Disease activity in MS is characterized by a mixture of inflammation and neurodegeneration. Clinically, this manifests as relapses and accumulation of disability. Treatments aim to reduce disease activity. We intuitively realize that after starting a treatment, there's a delay between the time of treatment start and the attainment of full clinical treatment effect. This delay is referred to as therapeutic lag. Accurate knowledge of the duration of therapeutic lag is clinically important. This is true not only for treatment-naive patients, but also for patients looking to transition from one therapy to another for safety, tolerability, or efficacy reasons. In this study, we aimed to develop a method that allows identification of the time to full clinically manifest effect of MS treatments. We aimed to address this question by turning to large cohorts of patients from two real-world observational registries, MSBase, the largest international MS registry, and OFSEP, the French National Registry. We identified patients with clinically isolated syndrome or relapsing remitting multiple sclerosis who started a MS-specific therapy and continued this treatment for at least 1 year. All patients required at least 3-year pre-treatment follow-up and annual review. In the situation where a single patient was started on multiple eligible treatments, multiple treatment epochs were studied. By setting the time a treatment was started as time point 0, we then identified all relapses and disability progression events in the 3 years before and 1 year after starting a treatment for relapses, or 3 years before and 5 years after starting a treatment for disability progression. We plotted these as density curves for each sufficiently represented treatment. Treatments with fewer than 300 events were not included, as a representative density curve could not be created. By analyzing relapses or progression events at a group level, trends were identified. Relapses and progression events peaked before treatments are started. This makes intuitive sense, as treatment starts or switches are prompted by disease activity. The number of events start decreasing before treatments are started, because by definition, only one relapse can occur every 30 days, and partially because of regression to the mean. By performing Monte Carlo simulations using 80% of the population with 10,000 repetitions, the first local minimum of the first derivative, representing the stabilization in the rate of relapses or disability progression, was identified. This represents the duration of therapeutic lag. This method was initially developed in MSBase and then validated in OFSEP. A merged cohort was subsequently used. By using a method that was developed and validated in two non-overlapping cohorts, therapeutic lag for relapses was calculated for 10 therapies and ranged between 12 and 30 weeks. When exploring differences in the annualized relapse rate in the pre-treatment, pre-stabilization compared to the post-treatment, post-stabilization periods, significant differences in the annualized relapse rate were present for all therapies, apart from intramuscular interferon beta 1a. Therapeutic lag for disability progression was calculated for 7 therapies and ranged between 30 and 70 weeks. Objectively defining the periods of expected therapeutic lag allows insights into the evaluation of treatment response in randomized clinical trials and may guide clinical decision-making in patients who experience early on-treatment disease activity. This method will subsequently be applied in studies that evaluate the effect of patient and disease characteristics on therapeutic lag. Thank you.